Welcome to today's lecture on traumatic injuries to the teeth. In this session, we'll cover the epidemiology, causes, classification, and treatment of dental trauma. We'll discuss injuries to primary dentition, injuries to developing permanent teeth, treatment modalities for permanent dentition injuries, child physical abuse and its implications. Join me as we explore the various aspects of traumatic dental injuries and learn about their diagnosis and management. Dental trauma in childhood and adolescence. Dental trauma is prevalent in childhood and adolescence, with boys being affected nearly twice as often as girls. By the age of 5, 31 to 40% of boys and 16 to 30% of girls experience some form of dental trauma, while by age 12, these percentages dip to 12 to 33% for boys and 4 to 19% for girls. The majority of dental injuries involve the anterior teeth, particularly the maxillary central incisors. In the primary dentition, common injuries include concussion, subluxation, and luxation, while in the permanent dentition, uncomplicated crown fractures are most prevalent. Prognosis for traumatic dental injuries has significantly improved over the past 2 decades. Largely attributed to advancements in understanding and knowledge of pulpal procedures. Etiology of dental trauma. Age-related susceptibility. Children aged 2 to 4 years are most prone to accidents affecting primary dentition, while those aged 7 to 10 years are at higher risk for permanent dentition injuries. Causes of injuries in primary dentition. Incomplete coordination and judgment, coupled with increased exploration, lead to falls within the home environment. Causes of injuries in permanent dentition, falls and collisions during play, often involving bicycles, are common. School playground accidents are prevalent globally. Sports-related injuries, teenage years often witness injuries, especially in contact sports. Road traffic accidents and assaults, common in late teenage years and adulthood, often linked to alcohol abuse. Non-accidental injuries, over 50% of physically abused children sustain orofacial injuries, necessitating vigilance. Types of trauma. Direct trauma affects the tooth directly, while indirect trauma occurs when the lower dental arch forcefully closes against the upper, possibly causing crown or crown root fractures in premolar and molar regions, as well as jaw fractures. Factors influencing injury outcome include energy impact, object resilience and shape, and angle of impacting force. Predisposing factors, increased overjet with upper incisor protrusion and insufficient lip closure elevate the risk of traumatic dental injuries, with protruding incisors doubling the frequency of injuries. Classification of dentoalveolar injuries. The World Health Organization, WHO, system categorizes dentoalveolar injuries as follows. Enamel fracture, limited to the enamel layer of the tooth. Enamel dentin fracture, extends through the enamel into the dentin layer. Uncomplicated fracture, involves enamel and dentin but does not expose the pulp. Complicated crown fracture, extends to the pulp, potentially leading to pulp necrosis. Crown root fracture, involves both the crown and root of the tooth. Root fracture, fracture occurs within the root portion of the tooth. Concussion is tender to percussion but does not exhibit mobility or displacement. Subluxation, tooth exhibits mobility but is not displaced. Luxation, tooth is displaced axially. Avulsion, complete displacement of the tooth from its socket. This classification system helps in assessing the severity of dental injuries and determining appropriate treatment strategies. History and examination. Dental history. Timing of injury. The time lapse between injury and treatment significantly impacts the prognosis of various dental injuries. Location of injury indicates the potential need for tetanus prophylaxis. Nature of injury. Understanding how the injury occurs provides insights into the expected type of dental trauma. Inconsistencies between history and clinical findings may raise suspicion of physical abuse. Lost teeth/fragments. In cases of tooth loss or fractured pieces, particularly when associated with loss of consciousness, a chest radiograph may be necessary to inhalation. Symptoms such as concussion, headache, vomiting, or amnesia warrant investigation for possible brain damage and referral to a hospital. Previous dental history. previous trauma can influence pulpal sensibility tests and the healing capacity of the pulp and periodontium. Additionally, previous experiences with dental treatment, the patient's age, and parental/child attitudes can influence treatment decisions. Medical history. Cardiovascular conditions, congenital heart disease, history of rheumatic fever, or severe immunosuppression may contraindicate procedures requiring prolonged endodontic treatment with persistent necrotic/infected focus. Consultation with the child's pediatrician/cardiologist is essential initiating endodontic treatment. Bleeding disorders, vital information if soft tissues are lacerated or tooth extractions are planned. Allergies, penicillin allergy necessitates alternative antibiotics. Tetanus immunization, referral for tetanus toxoid injection is warranted in cases of soil contamination if the child has not received a booster injection within the last 5 years. Medical history. Cardiovascular conditions, congenital heart disease, history of rheumatic fever, or severe immunosuppression may contraindicate procedures requiring prolonged endodontic treatment with persistent necrotic/infected focus. Consultation with the child's pediatrician/cardiologist is essential initiating endodontic treatment. Bleeding disorders, vital information if soft tissues are lacerated or tooth extractions are planned. Allergies, penicillin allergy necessitates alternative antibiotics. Tetanus immunization, referral for tetanus toxoid injection is warranted in cases of soil contamination if the child has not received a booster injection within the last 5 years. Intraoral examination. Systematic assessment. Mucosal and gingival examination, note lacerations, hemorrhage, and swelling. Lacerations should be inspected for tooth fragments or foreign material. While lip or tongue lacerations may require suturing, oral mucosal lacerations can heal quickly and may not necessitate suturing. Occlusal abnormalities, assess for abnormalities in occlusion, tooth displacement, fractured crowns, or enamel cracks. Helpful signs and test reactions. Mobility, assess mobility horizontally and vertically. En-bloc movement of several teeth may indicate alveolar process fracture, while excessive mobility may suggest root fracture or tooth displacement. Percussion reaction, compare the percussion reaction in horizontal and vertical directions with an uninjured contralateral tooth. A dull note may indicate root fracture. Tooth color, early color change indicating pulp breakdown, may be visible on the palatal surface of the gingival third of the crown. Sensitivity tests, conduct sensitivity tests using warm gutta percha, ethyl chloride, or an electric pulp tester. However, sensitivity testing is unreliable, especially in children, and should be interpreted along other clinical and radiographic findings. Always document the reactions of uninjured contralateral teeth for comparison. A 12-year-old child presented with an enamel and dentine fracture of the upper right permanent central incisor. B. The lower lip was swollen with a mucosal laceration. C. A lateral radiograph confirmed the presence of tooth fragments in the lip. D. Fragments were retrieved from the lip under local anesthesia. Radiographic examination. Periapical films utilize the reproducible long cone technique for accurate diagnosis. 2 radiographs at different angles may be necessary to detect root fractures. Occlusal view detects root fractures intraorally and foreign bodies within soft tissues when held by the patient or helper at the side of the mouth in a lateral view. Orthopantomogram (OPG) essential for trauma cases suspected of underlying bony injury. Trauma stamp. A standardized record combining clinical and radiographic examinations, aiding in clinical decision-making and follow-up appointments. Photographic records. Clinical photography importance. High-quality clinical photographs serve as valuable tools for assessing treatment outcomes and for potential medico-legal purposes. Consent requirement. Written consent is essential before capturing clinical photographs. Digital image management. For digital images, uncropped originals must be securely stored in an appropriate format and location to ensure confidentiality and data integrity. Injuries to the primary dentition. Primary tooth development. During early development, the permanent incisor is positioned palatally and in close proximity to the apex of the primary incisor. Any injury to a primary tooth poses a risk of damage to the underlying permanent successor. Age of occurrence. Accidents in the primary dentition occur between 2 and 4 years of age, limiting the feasibility of restorative procedures. Treatment options. For traumatized primary teeth, the decision often lies between extraction or maintenance without extensive treatment. Extraction is necessary if maintaining the primary tooth jeopardizes the tooth bud. Regular assessment. Retained traumatized primary teeth should be regularly assessed for signs of pulpal or periodontal complications, with radiographs aiding in detecting damage to the permanent successor. Soft tissue and tooth injury assessment. Soft tissue injuries in children should be assessed weekly while tooth injuries should be reviewed every 3 to 4 months in the first year and annually thereafter until exfoliation of the primary tooth and eruption of the permanent successor. Interference with development. Traumatic injuries before primary tooth eruption can interfere with their development. Treatment of uncomplicated crown fracture, primation. Smooth sharp edges or restore with an acid etch restoration if cooperation is satisfactory. Treatment of complicated crown fracture, primary dentition. Extraction is typically the treatment of choice. However, if cooperation is reasonable, pulp extirpation and canal obturation with zinc oxide cement, followed by an acid etch restoration, may be possible. Specific types of dental trauma in primary dentition. 1. Crown root fracture. The pulp is often exposed, making restorative treatment challenging. Extraction is usually the best course of action. 2. Root fracture. If there is minimal displacement and mobility, observation is advised. If the coronal fragment becomes non-vital and symptomatic, it should be removed, while the apical portion typically remains vital and undergoes normal resorption. In cases of marked displacement and mobility, only the coronal portion should be removed. 3. Concussion, subluxation, and lux injuries. Associated soft tissue damage should be cleaned twice daily with 0.2% chlorhexidine solution until healed. Concussion, often not brought to a dentist's attention until discoloration occurs. Subluxation, slight mobility warrants a soft diet and proper hygiene, while marked mobility may require extraction. Extrusive luxation, marked mobility often requires extraction. Lateral luxation, treatment depends on the direction of displacement. Conservative treatment may be possible if there is no occlusal interference, but extraction may be necessary if the apex is displaced towards the tooth bud. Intrusive luxation, radiological examination determines displacement direction. Extraction is often necessary if the root is displaced towards the permanent successor, while periodic review is required if the root is displaced buccally. 4. Exarticulation, avulsion. Implantation of avulsed primary incisors is not recommended due to the risk of damaging permanent tooth germs. Space maintenance is unnecessary following loss, as only minor drifting of adjacent teeth occurs. Eruption of the permanent successor may be delayed due to abnormal thickening of connective tissue overlying the tooth germ. Intrusive luxation. Common type of injury. Intrusive luxation is the most common type of dental injury. Investigation aim. Establish the direction of displacement through thorough radiological examination. Palatal displacement. If the root is displaced palatally toward permanent successor. Extract the primary tooth to minimize possible damage to the developing permanent successor. Buccal displacement. If the root is displaced buccally. Periodic review is necessary to monitor spontaneous re-eruption. Weekly review for a month, then monthly for a max 6 months. Most re-eruption occurs between 1 and 6 months. Ankylosis risk. If re-eruption doesn't occur, ankylosis is likely. Extraction is necessary to prevent ectopic eruption of the permanent successor. A 4-year-old boy with complete intrusion of the upper right incisor. B. 6 months post-trauma, the tooth has spontaneously re-erupted. Sequelae of injuries to the primary dentition. 1. Pulpal necrosis. Evaluation. Necrosis is the most common complication, assessed based on color and radiography. Normally colored teeth rarely develop periapical inflammation, while mildly discolored teeth may still be vital. Color indicators. A mild gray color shortly after trauma may indicate interpulpal bleeding with a still vital pulp. Persistent discoloration suggests necrosis. Radiographic examination, necessary every 3 months to check for periapical inflammation. Failure of the pulp cavity to reduce in size indicates pulp. Extraction is recommended upon evidence of periapical inflammation to prevent potential harm to the permanent successor. 2. Pulpal obliteration. Reaction to trauma, common reaction resulting in pulp chamber and canal obliteration, clinically manifesting as a yellow/opaque tooth. Normal exfoliation typically occurs, but periodic radiography is advisable to monitor for any periapical inflammation. 3. Root resorption. Indication for extraction. Extraction is recommended for all types of root resorption with evidence of infection. Types of injuries to developing teeth. Hypomineralization of enamel, white or yellow-brown, injury at 2 to 7 years. Hypomineralization with circular enamel hypoplasia, injury at 2 to 7 years. Crown delaceration, injury at about 2 years. Odontoma-like malformation, injury at 1 to 3 years. Root duplication, injury at 2 to 5 years. Vestibular or lateral root angulation and delaceration, injury at 2 to 5 years. Partial or complete arrest of root formation, injury at 5 to 7 years. Sequestration of permanent tooth germs. Disturbance in eruption. Treatment of injuries to the permanent dentition. Yellow-brown hypomineralization of enamel. Acid pumice microabrasion. Composite resin restoration, localized, veneer, or crown. Porcelain restoration. Veneer or crown, anterior. Fused to metal crown, posterior. Conservative approaches are preferred whenever possible. Delaceration and angulation in tooth injuries. Delaceration definition, abrupt deviation of the long axis of the crown or root portion of the tooth due to traumatic displacement of already formed hard tissue relative to developing soft tissue. Angulation definition, curvature of the root resulting from a gradual change in the direct root development, without evidence of abrupt displacement of the tooth germ during odontogenesis. It can be vestibular, labiopalatal, or lateral, mesiodistal. Evaluation of complications. Full assessment of complications following injuries requires complete eruption of all involved permanent teeth. However, serious sequelae, disturbances in tooth morphology, are typically diagnosable radiographically within the first year post-trauma. Eruption disturbances, delayed eruption due to thickening of connective tissue over a permanent tooth germ, ectopic eruption from lack of eruptive guidance, and impaction in teeth with crown or root malformations are consequences. Key points in primary tooth trauma. Risk of damage to permanent successors is high, parents should be warned. Intrusive injuries pose the highest risk to permanent successors. Crown delaceration. Surgical exposure plus orthodontic realignment. Removal of delacerated part of crown. Temporary crown until root formation complete. Semi-permanent or permanent restoration. Vestibular root angulation, combined surgical and orthodontic realignment. Other malformation, extraction, is usually the treatment of choice. Disturbance and eruption, surgical exposure, plus orthodontic realignment. Injuries to supporting bone. Alveolar socket fractures in primary dentition usually do not require splinting due to rapid bony healing in small children. Jaw fractures, treated conventionally, although stabilization after reduction may be challenging due to insufficient adjacent teeth. Treatment of injuries to the permanent dentition. Emergency treatment. Retain vitality of fractured or displaced tooth. Treat exposed pulp tissue. Reduction and immobilization of displaced teeth. Antiseptic mouthwash plus or minus antibiotics and tetanus prophylaxis. Intermediate treatment. Emergency treatment plus. Pulp therapy. Minimally invasive crown restoration. Permanent treatment. Apexogenesis/apexification. Root filling plus root extrusion. Gingival and alveolar collar modification. Semi-permanent or permanent coronal restoration. Follow-up protocol. Trauma cases require meticulous follow-up to identify complications and institute appropriate treatment. Utilize the trauma stamp for comprehensive record keeping. Follow-up schedule: 1 week, 1, 3, and 12 months, then annually for 4 to 5 years. Injuries to the hard dental tissues and the pulp enamel and fraction. Incomplete fractures without loss of tooth substance. Easily overlooked without proper illumination. Review is necessary to assess potential transmission of energy to periodontal tissues or pulp. Enamel fracture. No restoration needed, treatment limited to smoothing rough edges and splinting if associated mobility. Periodic review advised. Enamel dentine, uncomplicated, fracture. Immediate treatment required to protect the pulp against thermal osmotic irritation and bacterial invasion via dentinal tubules. Restoration of crown morphology stabilizes tooth position in the arch. Emergency protection of exposed dentine. Composite resin or compomer bandage. Glass ionomer cement within orthodontic band or incisal end of stainless steel crown if insufficient enamel available for acid etch technique. Intermediate restoration. Acid-etched composite applied freehand or using celluloid crown former. Reattachment of crown fragment with uncertain longevity. Reattachment technique. Fit fragment and assess tooth vitality. Clean fragment and tooth. Isolate tooth with rubber dam. Attach fragment to sticky wax. Etch enamel, apply bonding agent, and light cure. Apply appropriate shade of composite resin, position fragment, and cure. Remove excess resin. Create gutter of enamel on each side of fracture line. Etch, apply composite, cure, and finish. Enamel dentine pulp, complicated, crown fracture. Role of pulp in tooth development. The pulp is crucial in tooth development. It lays down dentine, forming the basic structure of teeth. Defines tooth morphology and provides mechanical strength. Dentine deposition. Dentine deposition begins years before permanent tooth eruption. Even after eruption, the pulp contributes to root development. Characteristics of newly erupted teeth. Short roots, wide apices, and thin dentine walls. Relatively weak compared to mature teeth. Consequences of pulp vitality loss. Loss of pulp vitality before tooth maturity can lead to vulnerability to fracture. Unfavorable crown-root ratio. Challenges in endodontic treatment. Endodontic treatment of non-vital immature teeth can be challenging. May affect long-term prognosis. After pulpal exposures in immature teeth. preventing physical, chemical, and microbial invasion. Preserving pulpal vitality for continued root growth. Repair capacity of healthy radicular pulp. Healthy radicular pulp has a significant capacity for repair. Infected and inflamed coronal removal is crucial. Appropriate wound dressing and sealing coronal restoration are necessary. Treatment options. Partial pulpotomy. Complete coronal pulpotomy. Pulp capping, depending on the circumstances. Vital pulp therapy, pulp capping. Procedure. Must be performed within 24 hours of the incident. Isolate the tooth with rubber dam. Avoid inserting instruments into the exposure site. Control bleeding with sterile cotton wool moistened with saline or sodium hypochlorite. Avoid using air blasts from a 3-in-1 syringe to prevent driving debris and microorganisms into the pulp. Apply a layer of setting calcium hydroxide cement gently onto the exposed pulp and surrounding dentine. Quickly overlay with a bandage of adhesive material, e.g., compomer, for temporary protection until definitive aesthetic restoration can be performed later. Successful direct pulp cap should preserve the remaining pulp in health and promote the deposition of reparative dentine to seal off the exposure site. Follow-up. Review after 1 month, then at 3 months, and eventually at 6-month intervals for up to years to assess pulp vitality. Arrange periodic radiographic reviews to monitor dentine bridge formation, root growth, and exclude necrosis and resorption. On the radiograph, check for root length growth, maturation of the root canal, narrowing. Compare with the contralateral. Lack of growth may indicate non-vital pulp. Vital pulp therapy, pulpotomy. In pulpotomy, a portion of the exposed vital pulp is removed to preserve radicular vitality and facilitate the completion of apical root development, apexogenesis, and further dentine deposition on the root walls. This procedure is preferred following trauma where the pulp has been exposed to health for more than 24 hours. Procedure. Patient evaluation. Determine the extent of pulp exposure and contamination based on the time since exposure. Local anesthesia and isolation. Administer local anesthesia and isolate the tooth with a rubber dam. Pulp tissue excision. Excise pulp using a high-speed diamond burr under constant water cooling. This minimizes injury to the underlying pulp. For exposures within 24 to 48 hours, remove only the contaminated pulp in the immediate vicinity of the exposure. Partial pulpotomy, KVEX technique. For more extensive exposures, all coronal pulp down to the cervical constriction of the tooth, coronal pulpotomy. Control bleeding and cleanse. Control bleeding with moist cotton wool. Excessive bleeding or no bleeding indicates the need for further tissue excision. Rinse the wound with sterile saline or sodium hypochlorite to remove any shredded tissue. Application of calcium hydroxide dressing. Apply a calcium hydroxide dressing to the pulp to destroy remaining microorganisms and promote calcific repair. For superficial wounds, use setting calcium hydroxide cement gently flowed onto the pulp surface. For deeper excisions, prepare a stiff mixture of calcium hydroxide powder in sterile saline or local anesthetic solution and pack it into the canal using an amalgam carrier. Post-procedure care. Monitor the tooth regularly for healing and assess pulp vitality. Periodic radiographic evaluations may be necessary. Overlay with hard cement. Overlay the calcium hydroxide dressing with a hard cement to prevent its forceful injection into the pulp due to chewing forces. Final adhesive restoration. Apply a final adhesive restoration to seal the preparation against the re-entry of microorganisms. Review schedule. After a month, assess healing and pulp vitality. At 3 months, monitor progress and assess any changes. At 6 monthly intervals for up to 4 years, continuously assess pulp vitality and overall tooth health over an extended period. Procedure. Pulp amputation, apexogenesis of a permanent incisor. A. Initial condition. Complicated fracture of an immature incisor with microbial invasion of the coronal pulp. Pulp exposed to the oral cavity for more than 24 hours. B. treatment steps. Access to the coronal pulp. Amputation of coronal pulp tissue using a diamond burr at high speed with constant water cooling. C. Pulpal wound dressing. Dressing the pulpal wound to promote calcific repair. Non-setting calcium hydroxide cement flowed onto the pulp, overlaid with hard cement. Restoration of the tooth with composite resin. D. After 12 months. Calcific barrier formation observed. Direct inspection of the calcific barrier, not always required. A new layer of setting calcium hydroxide cement placed on the barrier before definitive restoration. Remaining pulp remains healthy, deposits dentine to complete root formation. Radiographic monitoring, arrange periodic radiographic reviews to monitor dentine bridge formation. Track root growth. Exclude the development of necrosis and resorption. Non-vital pulp therapy. If vitality is lost, non-vital pulp therapy should be initiated, regardless of the presence of a calcific bridge. Success rates. Partial, CVEC, pulpotomies, 97% success rate. Coronal pulpotomies, 75% success rate. Elective pulpectomy. Consider elective pulpectomy and root canal treatment of a vital pulp only if the root canal is necessary for restorative purposes at a later date. Non-vital pulp therapy, pulpectomy. Dealing with pulp death in immature teeth poses challenges due to thin dentine walls, wide open apex, and lack of further root development. The primary goal is to eliminate bacterial infection from the root canal and prevent reinfection. Challenges. Dentine walls are prone to fracture under physiological forces. Lack of further root development complicates treatment. Treatment approach. Bacterial elimination. The first step is to thoroughly disinfect the root canal space, preventing reinfection. Without a natural apical constriction, preventing reinfection challenging. Creating a barrier. Traditionally, treatment aimed to create a barrier against which root canal filling material could be placed, preventing extrusion into surrounding tissues. Apexification with calcium hydroxide. Prolonged dressing with calcium hydroxide has been a common method to achieve apexification. Concerns with calcium hydroxide. Long-term use of calcium hydroxide may desiccate dentinal proteins, making dentine more brittle and prone to fractures. Increased prevalence of root fractures has been reported in teeth treated with calcium hydroxide, raising concerns about its long-term use. Avoiding prolonged use of calcium hydroxide. In this chapter, while we describe the technique for calcium hydroxide apexification for completeness, it's advised to minimize its prolonged use in root canals. Alternative methods like mineral trioxide aggregate and regenerative endodontic techniques are preferable and in later sections. Operative procedure. Access. Use a high-speed medium tapered Fisher burr to access the pulp chamber without overcutting or perforation. Debris removal. Remove loose debris from the pulp chamber using hand instruments and gentle irrigation with sodium hypochlorite solution. Canal preparation. Clean the root canal system with irrigants and shape it with enlarging instruments to allow placement of a well-condensed root filling. Irrigation. Use sodium hypochlorite solution as an irrigant to dissolve organic debris and kill microorganisms. Instrumentation. Direct files around the canal walls with a light rasping action. Remove adherent debris, frequently punctuated by irrigation to flush out debris. Provisional working length. Establish a provisional working length 2 to 3 mm from the radiographic apex and then establish a definitive working length 1 mm short of the radiographic root apex. Drying. Dry the canal with pre-measured paper to avoid overextension and damage to periapical tissues. This approach aims to effectively disinfect the root canal space and prepare it for further treatment while minimizing the risks associated with prolonged use of calcium hydroxide. Canal filling with calcium hydroxide paste. Fill the canal. Use a relatively fluid proprietary calcium hydroxide paste such as Ultracal, Optident, UK. This can be syringed into the canal via a disposable flexible tip or spun into the canal with a spiral paste filler. Continuing, the non-setting calcium hydroxide will continue to cleanse the canal and encourage calcific root end closure due to its antimicrobial properties and high pH. Radiographic confirmation. take a radiograph to ensure a dense fill to each root terminus. Seal access cavity. Seal the access cavity tightly between appointments to prevent leaching of calcium hydroxide and re-entry of microorganisms. A 3 mm thickness of glass ionomer cement or composite resin is adequate for a bacteriatight seal. Review. Every 3 months, monitor root end closure. Wash the calcium hydroxide dressing for canal and assess the presence of a calcified barrier by tapping a pre-measured paper point at the working length. Radiographs. Take radiographs to assess the progress of barrier formation. Completion of barrier formation. If the calcific barrier formation is complete, obturation can proceed. If not complete, redress for a further 3 months. Calcific barrier formation usually completes within 9 to 18 months, but could take up to 2 years. Root end closure. Predictable results if infection is controlled and the canal is sealed bacteriatight. Controlled by irrigation and disinfection. Enlarge the canal enough only to allow irrigant access and dense obturation. Adds nothing to the strength of the tooth. Coronal restoration is critical for long-term success. Techniques for obturation. Cold lateral condensation of gutta-percha, GP, and sealer may suffice in regular apicleaking canals. In irregular and diverging canals, a thermoplastic GP technique is required to improve adaptation. Single cone techniques are not recommended in any circumstances. Manual obturation in apically divergent canal. Select master point. Choose the widest point that will reach the canal terminus, which may need to be inverted in wider canals. Coat canal walls. Dry the canal and lightly coat its walls with a slow-setting sealer. Softening master point. Soften the tip of the point by passing it through a Bunsen burner flame. Insert it to the apical limit of the canal and gently press against the calcific barrier to adapt the softened gutta-percha, GP. Cold lateral condensation. Use a spreader to apply cold lateral condensation within 1 mm of the apical limit of the canal. Add accessory cones lightly coated with sealer. Continue condensation until the spreader can advance no more than 2 or 3 mm into the canal. Check radiograph. Assess the quality of fill before removing excess GP with a hot instrument and vertically condensing warm GP at the canal entrance. Condensation may be done if needed for a uniformly dense obturation. Thermoplastic obturation. Coat canal walls. Dry the canal and lightly coat its walls with a slow-setting sealer. Inject thermoplastic GP. Inject thermoplastic GP into the apical portion of the canal and condense. Radiograph check. Verify the apical GP is in the correct place. Backfill. Backfill with GP and seal the access cavity with an adhesive restoration. While root end closure adds nothing to the canal wall thickness or mechanical strength of immature teeth, the final restoration should aim to optimize the durability of the remaining tooth. Dentine-bonded composite resins and light-transmitting fiber posts are potential options for rehabilitation and internal splinting. Periodic clinical and radiographic reviews should be arranged. Alternatives to apexification with calcium hydroxide. Mineral trioxide aggregate, MTA, preferred over calcium hydroxide for apexification. Regenerative endodontic technique, another preferred alternative to apexification with calcium hydroxide. Use of mineral trioxide aggregate, MTA. Introduction and revolution. In the past decade, MTA has revolutionized endodontic procedures. Enables creation of a plug for immediate root canal obturation. Composition and application. MTA is based on Portland cement. Packed into canal using pre-measured pluggers. Sets to form a hard, sealing, biocompatible barrier within 30 minutes. Setting process. Moist cotton wool placed in canal for 30 minutes to promote setting. Check setting with paper point or file gently. Immediate obturation. Root canal obturated with gutta-percha, GP, and sealer in the same visit. Clinical studies and recommendation. Numerous studies support MTA as material of choice for incomplete root development. Advantages. Facilitates root end closure and obturation in visit. Reduces need for patient compliance. Cost effectiveness increased due to fewer treatment visits compared to multiple visit procedures. Alternative applications. In cases of lost pulp vitality in almost fully formed teeth, lengthy root end closure procedures can sometimes be avoided. 8 apical stop against which root filling can be packed. Endodontic hand files used for gentle watch winding or balanced force motion to shave apical seat for canal obturation. MTA can be packed into apical 1 to 2 mm of canal with pluggers to provide immediate apical seal. Regenerative endodontic technique, RET. Introduction. Shift in treatment approach for non-vital incisors with incomplete root development. Aims to harness stem cells in apical area for repopulation of root canal with vital tissue. Concept. Enables continued deposition of hard tissue and potential further root development. Also known as regenerative endodontic technique, RET, Bench-Centrope, 2004. Rationale. Stem cell biology advancements allow aspiration for further root development and hard tissue deposition. Differs from revascularization, whilst reattaching blood supply. RET involves regeneration by repopulating root canal with vital tissue. Stem cells of the apical papilla, scap. Apical area of incomplete root development rich in scap. Scap cells, characterized similar to dental pulp progenitor cells. Procedure. Requires intense disinfection within root canal system. Provision of biological scaffold and signaling. Stem cells from scap migrate into scaffold and root canal and repopulate it with vital tissue. Success and evidence. Demonstrated in numerous case reports and medium-term studies. Success indicated by regeneration of vital tissue within root canal. Advantages. Vital tissue production reinforces root canal system. Reduces susceptibility of roots to fracture, a common issue with conventional endodontic methods. Potential for further root development enhances long-term prognosis. Clinical technique for regenerative endodontic technique, RET. Preparation. All procedures are conducted under local anesthesia and rubber dam isolation. Pulpal extirpation is performed, followed by copious irrigation of root canals with mild disinfectants for 30 minutes. Minimal or no filing of the root canal is done to prevent further weakening of existing dentinal walls. Antibiotic dressing. A mixture of antibiotics is prepared, commonly including minocycline, ciprofloxacin, and metronidazole. These antibiotics are mixed in distilled water or propylene glycol and introduced into the root canal using a syringe or spiral paste filler. To avoid discoloration, especially with minocycline, ensure no antibiotic is in the pulp chamber or coronal part of the tooth. Temporary sealing and review. The tooth is temporarily sealed, and a review is scheduled in 2 weeks. If no periapical infection is observed at the review, the root canal is reaccessed, and the antibiotics are flushed out with saline. Induction of bleeding. At the reaccess appointment, a sterile 23-gauge needle is inserted past the confines of the root canal into the periapical tissues to induce bleeding into the root canal. Once fraying is evident at the cervical portion of the root canal, a cotton pellet is inserted 3 to 4 mm into the canal below the cervical margins and held there for 7 to 10 minutes to allow formation of a blood clot in the apical 2/3 of the canal. Sealing and radiographic evaluation. The access is sealed with materials like MT or glass ionomer cements to prevent coronal leakage, extending about 4 mm into the coronal portion of the root canal. Avoid MTA if discoloration is a concern. Periapical radiographs are taken as baseline records, essential for comparison with future radiographs every 6 months to ascertain continued development, hard tissue deposition in the root canal, and the success of treatment. Endodontic surgery versus advancements. Decreasing popularity of endodontic surgery. Advancements in techniques like MTA for root end closure have reduced the popularity of endodontic surgery. MTA offers efficient root end closure without the need for surgery. Considerations for endodontic surgery. Still considered in cases of serious irretrievable overfill. Erroneously diagnosed calcific barrier as complete or broken. Concerns about calcium hydroxide. Prolonged use in root canal should be avoided. Concerns regarding long-term effects on dentine. Alternate techniques. MTA, preferred for root end closure. Regenerative endodontic technique, RET. Considered when MTA is insufficient. Especially applicable when root development is incomplete. Useful for teeth with poor prognosis even with MTA. Decision makers. Selection between MTA, RET, and endodontic surgery depends on case-specific factors. Prognosis of the tooth. Effectiveness of each technique in achieving desired outcomes. Continued evolution. As techniques evolve, the approach to managing endodontic cases continues to refine. Regular updates and advancements contribute to improved patient outcomes and reduced invasiveness of procedures. Management of crown root fractures. Uncomplicated cases. Remove fractured piece. Bring fracture margin supragingival via gingivoplasty or root extrusion. Complicated cases. Add endodontic treatment if necessary. Ensure final root length matches final crown length for stability if extrusion planned. Root extrusion. Potential for stable periodontal condition. Success relies on proper execution and patient cooperation. Considerations. Patient cooperation. Patient motion crucial for successful outcome. Endodontic treatment. Essential in complicated cases to preserve tooth vitality and prevent complications. Final stability. Match final root length with crown length for stability, especially in extrusion cases. Management of root fractures. Fracture localization. Typically occurs in middle or apical third of the root. Coronal fragment may be extruded or luxated. Prompt repositioning. Essential for optimal healing with hard tissue. Reduces risk of pulpal necrosis. Splinting. Mobilize mobile root fractures for about 4 weeks. Utilize semi-rigid or functional splint. Prolonged splinting may be necessary in some cases. Categories of repair. Repair can involve calcified tissue, connective tissue, bone and connective tissue. Pulp canal obliteration, common occurrence in root fractures. Fractures in cervical third may necessitate extraction of coronal fragment. Retain remaining root and consider various treatment options such as post, core, and crown restoration or orthodontic extrusion for adequate access. Extraction of coronal fragment and root retention. Radicular pulp removal. Remove remaining radicular pulp. Temporarily dress the canal. Options for treated radicular portion. Post, core, and crown restoration. If access is adequate. Orthodontic extrusion. If fracture extends subgingivally. Rapid orthodontic extrusion over 4 to 6 weeks using a J-hook and elastic traction. Retain for a month to prevent relapse. Aesthetic concerns addressed by bonding orthodontic bracket to temporary crown over J-hook. Cover root for future implant placement. Cover root with mucoperiosteal flap. Internal splinting. Used for fractures in coronal and middle third of the root. Aim to splint coronal and apical portions internally with rigid root filling material. Previous approaches include headstrom files or nickel chromium points, screwed and cemented into position. Limited efficacy in preventing re-entry of oral microorganisms and fracture line. Other restorative options preferred due to their efficacy and durability. Pulpal necrosis in root fracture. Incidence and impedance. Occurs in approximately 20% of root fractures. Hampers adequate repair of the fracture. Determinants of pulpal prognosis. Initial displacement of coronal portion, not level of fracture or apex status, determines pulpal prognosis. Diagnosis. Typically made within 3 months post-injury. Confirmed by persistent negative response to electric stimulation and radiographic radiolucencies adjacent to fracture line. Pulpal status in apical fragment. Apical fragment usually can viable pulp tissue initially. Tissue may undergo sclerosis and might necessitate surgical removal eventually. Endodontic treatment approach. limited to coronal fragment in apical and middle third fractures. Establish barrier on coronal aspect of fracture line with non-setting calcium hydroxide (MTA). Coronal canal obturated with gutta percha (GP). Repair process. Repair and union between fragments with connective tissue are commonly observed after endodontic treatment. Treatment options for coronal third fractures with necrosis. Retaining radicular portion. Keep radicular portion of the tooth. Address necrosis through appropriate endodontic treatment. Extracting both portions. Remove both coronal and radicular portions of the tooth. Prosthetic replacement options. Internally splinting the fracture. Utilize splinting to immobilize the tooth and promote healing. Splinting considerations. Trauma effects. Trauma may damage periodontal ligament, PDL, or fracture the root, necessitating splinting. Functional versus rigid splint. Functional splint involves one abutment tooth on each side of the injured tooth. Rigid splint involves two abutment teeth. Healing period for PDL injuries. Typically complete within a month. Splinting periods kept as short as possible to prevent replacement root resorption. Splinting periods. Avulsion injuries typically require 14 days of splinting. Luxation injuries require 2 to 4 weeks of functional splinting. Splinting period for root fractures. Apical and middle third fractures usually require weeks of functional splinting. Coronal third fractures may require 8 weeks of functional splinting. Risk of excessive mobility. Excessive mobility can lead to granulation tissue filling the fracture site. Rigid splinting for dentoalveolar fractures. Duration. Typically required for 3 to 4 weeks. Construction of composite resin / acrylic and wire splint. Preparation. Bend flexible orthodontic wire to fit middle third of labial surface of injured tooth and one abutment on each side. Stabilize injured tooth with soft red wax palatally. Application. Clean, isolate, dry, and etch middle of crown of teeth with 37% phosphoric acid. Apply 3 mm diameter circle of composite or acrylic resin to crown centers. Position wire into filling material and apply more resin. Mold and smooth resin using brush lubricated with unfilled resin, or acrylic resin using flat plastic instrument. Curing and finishing. Cure composite for 60 seconds or wait for acrylic resin to cure. Smooth any edges with sandpaper discs. Prefabricated titanium trauma splint, TTS splint. Commercially available option. Advantages. Ease of adaptation. Easy application with composite resin. Ease of removal. Retention of physiological tooth mobility essential for healing of periodontal ligament. Considerations for rigid splints. Incorporate 2 abutment teeth on each side of injured tooth. Ensure splints do not impinge on gingiva. Allow assessment of color change and sensitivity testing. Laboratory splints. Purpose. Used when direct splinting methods are impractical, such as in cases involving very young patients with traumatized teeth or other complicating factors. Types. Acrylic splint. Design. Provides full palatal coverage. Extends over the incisal edges for 2 to 3 mm of the labial surfaces of the anterior teeth. Occlusal surfaces of posterior teeth covered to prevent occlusal contact in anterior region. Removal. Necessary for cleaning after meals and at bedtime. Thermoplastic splint. Material. Constructed from polyvinyl acetate polyethylene, FACPE, copolymer. Design. Similar to a mouthguard. Extends onto the mucosa. Removal. Similar to acrylic splint, removed after meals and at bedtime. In case severely loosened teeth, may be retained at night. Functionality. Both types allow for functional movement, promoting normal periodontal healing. Limitations. Not suitable for root fractures as they can compromise oral hygiene. Treatment approaches for periodontal tissue injuries. Concussion. Symptoms: tooth tenderness to percussion, TTP, edema, and hemorrhage in the periodontal ligament, PDL. Treatment: occlusal relief. Soft diet for 7 days. Immobilization with functional splint for 2 weeks if teeth have fully formed apices or significant TTP. Chlorhexidine 0.2% mouthwash twice daily. Subluxation. Symptoms: tooth mobility within socket due to PDL fiber rupture. Treatment: similar to concussion, with attention to severity of tooth mobility and PDL injury. Extrusive luxation. Symptoms: rupture of PDL and pulp. Treatment: atraumatic repositioning. Functional splint for 2 weeks. Antibiotics and chlorhexidine mouthwash. Diet for 2 to 3 weeks. Lateral luxation. Symptoms: rupture of PDL, pulp, and alveolar plate. Treatment: atraumatic repositioning. Non-rigid functional splint for 4 weeks. Antibiotics and chlorhexidine mouthwash. Diet for 2 to 3 weeks. Goals of treatment: minimize complications. Promote healing. Preserve tooth vitality following traumatic injuries to periodontal tissues. Management of luxation injuries. Antibiotic use. Limited evidence supports the use of antibiotics for luxation injuries. Antibiotics may be considered based on soft tissue injuries and medical status, but their use remains discretionary. Splint removal. After 4 weeks, teeth should be radiographed to assess marginal breakdown. If no marginal breakdown is observed, the splint can be removed. If present, the splint should be retained for an additional 2 to 3 weeks. Endodontic treatment. The decision to proceed with endodontic treatment depends on clinical and radiographic signs at regular reviews. Prognosis is better for open apex teeth, but even mature, closed apex teeth may retain vitality. Transient apical breakdown, TAB, can mimic apical inflammation on radiographs, requiring careful consideration. Significant damage to the periodontal ligament, PDL, increases the risk of resorption. Reduction of displacement. Gentle finger pressure is used to reduce displacement in most cases. In cases where displacement cannot be reduced, orthodontic appliances, removable or sectional fixed, can be utilized over a few weeks to gradually reduce displacement without further damaging the PDL. A 7-year-old child with intrusion of the upper right permanent central incisor, which failed to re-erupt spontaneously. B. C. Orthodontic extrusion of the upper right central incisor. Management of avulsion and replantation of a tooth. Replantation of teeth with dry storage time less than 1 hour. Initial handling. Advise not to touch the root, hold by the crown. If dirty, briefly rinse under cold running water for 10 seconds. Replantation. Place tooth in socket if possible. If not possible, transport tooth in milk to dental office. Post-replantation. If replaced, gently bite on a handkerchief to retain it. Seek immediate dental treatment. Immediate surgery treatment. Handling and preparation. Not handle the root. If replanted, remove tooth from socket. Rinsing and examination. Rinse tooth with normal saline. Note state of root development. Local analgesia. Provide local analgesia to alleviate pain. Socket preparation. Irrigate socket with saline to remove clot and foreign material. Replantation procedure. Gently but firmly push tooth into socket. Ensure proper positioning. Splinting. Apply non-rigid functional splint for 14 days. Ensure proper alignment. Assessment and radiographs. Check occlusion. Take baseline radiographs to assess position and condition, medication and diet. Administer systemic antibiotics and chlorhexidine mouthwash. Advise soft diet to prevent further trauma. Tetanus immunization. Check tetanus immunization status for prophylaxis. Review and follow-up protocol for replanted teeth. Radiographic evaluation. Conduct radiograph before splint removal at 14 days. Splint removal. Remove splint at 14 days post-replantation. Endodontic treatment considerations. Commence endo treatment before splint removal in certain cases. A. Open apex, extraalveolar time, EAT, 30 to 45 minutes, observe. B. Open apex, EAT 30-45 minutes, endodontic treatment. C. Closed apex, endodontic treatment. Radiographic review. Perform radiographic review at specific intervals to monitor healing and resorption. Management of resorption. If resorption progresses unhalted, keep non-setting calcium hydroxide in the tooth until exfoliation, changing it every 6 months. Special consideration for short EAT to 45 minutes. Immature teeth with short dry storage time may undergo pulp revascularization. Regular clinical and radiographic review is necessary due to the risk of rapid external inflammatory resorption, EIR. Objective. Optimize chances of successful replantation. Minimize complications associated with avulsion injuries through systematic follow-up and appropriate interventions. Replantation protocol for teeth with dry storage time over 1 hour. Very immature apex, not recommended for replantation. Consensus opinion. Advises against replantation due to high rates of resorption, ankylosis, and subsequent loss, especially in younger individuals with rapid bone remodeling. Mature apex. Preparation. Remove necrotic periodontal ligament, PDL, and pulp at chairside using pumice and water on a bristle brush. Rinse with normal saline. Root canal obturation. Obture the root canal with gutta-percha, GP. Replantation and splinting. Replant tooth and splint for 4 weeks to induce ankylosis, maintaining tooth as natural space maintainer. Pulpal and periodontal status in PDL injuries. Complications. Pulpal necrosis is common, severity linked to extent of periodontal injury. Immature teeth have better prognosis due to wider apical openings. Diagnosis. May take up to 3 months post-injury, sometimes delayed for up to 2 years. Requires combination of clinical and radiographic signs. Sensitivity testing. Considerations. Negative electric pulp testing, EPT, post-trauma. Positive responses may occur months later. Postpone endodontic until other signs are present. Tooth discoloration. Indications. Pinkish discoloration initially indicates partial severance of apical vessels. Progressive gray discoloration suggests necrosis, especially if it appears weeks or months post-trauma. Tenderness to percussion. Indicator. Reliable indicator of pulpal necrosis, especially when other signs are present. Periapical inflammation. Radiological manifestation. Periapical involvement may manifest as early as 3 weeks post-trauma, indicating pulp necrosis and infection. Arrest of root development. Indicators. Pulp necrosis can halt root development, resulting in lack of further growth. Failure of pulp chamber and root canal to mature, compared to uninjured teeth on radiographs, is indicative of necrosis. Resorption. Root resorption is a significant complication following trauma to primary and permanent teeth. While primary teeth with resorptive lesions often require extraction, permanent teeth can often be successfully treated if the tissue destruction hasn't progressed too far. Forms of pathological root resorption. Inflammatory root resorption. Multinuclear giant cells rapidly colonize internal and external root surfaces after trauma. Continuous stimulation of these cells, typically by microbial products from infected root canals or periodontal pockets, can lead to progressive inflammatory root resorption. Classified into external inflammatory root resorption, cervical resorption, a variant of external resorption, and internal root resorption, also known as infection-related resorption. External inflammatory root resorption occurs in non-vital teeth with infected pulp canals. Damage to the periodontal PDL initiates resorptive activity, which is then fueled by infected root canal contents. Diagnosis is typically made through radiographic findings, characterized by changes in the external contour of the root and often surrounded by a bony licency. Treatment involves root canal cleaning and shaping, followed by with non-setting calcium hydroxide paste to control intercanal infection. Definitive obturation may follow after monitoring for lesion arrest. Periodic clinical and radiographic reviews are essential to assess treatment progress. Resorption, especially the inflammatory type, requires timely intervention to prevent further tissue destruction and preserve tooth integrity. Effective management involves controlling infection and closely monitoring the tooth's response to treatment. Cervical resorption. Cervical resorption is an uncommon type of external inflammatory root resorption that begins with damage to the root surface in the cervical region and is propagated by infected root canal contents or the periodontal microflora. The resorptive process may extend widely from a small entry point before reaching the pulper. Diagnosis. Sometimes clinically visible as a pink spot when extensively intercorneally extended. More commonly identified on routine radiographs by a characteristic radiolucency. Treatment. Non-vital tooth, conventional root canal therapy is recommended to eliminate the protruding stimulus. The resorptive defect is opened and curetted similarly to cavity preparation, followed by restoration of the defect. In some cases, raising a flap may be necessary to adequately eliminate resorptive tissue and contour the subgingival restoration. Vital tooth. If the pulp has not aided, treatment may involve opening and curetting the resorption lacuna, placing a setting calcium hydroxide lining, and restoring the defect with an appropriate material. Internal inflammatory root resorption. Seen in traumatized teeth with progressive pulp necrosis. Infected material in the non-vital coronal part of the canal propagates resorption by the underlying vital tissue, leading to rapid tissue destruction. Periodic clinical and radiographic reviews are essential for monitoring the progress of treatment and detecting any recurrence of resorption. Early intervention is crucial to prevent further tissue damage and preserve tooth function. Diagnosis. Large resorptive defects affecting the coronal third of the canal may manifest as a pink discoloration of the affected tooth or may be detected incidentally on radiographic examination. Radiographically, internal resorption presents as a rounded, symmetrical radiolucency centered on the root canal, with the contours of the root canal walls rarely superimposed. Treatment. Internal resorption should be treated promptly as a form of irreversible pulpitis. The following steps are typically involved. Access cavity preparation. Standard access cavity preparation is performed, often revealing necrotic debris in the pulp chamber and coronal portion of the canal. Root canal preparation. The canal is prepared in the usual manner, but deeper penetration may lead to significant hemorrhage as the vascular resorptive tissue is encountered. Sonic or ultrasonic devices can enhance instrumentation by throwing irrigant into uninstrumented areas. Irrigation. Sodium hypochlorite is the preferred irrigant to its antimicrobial and tissue solvent actions. Medication. After debridement, the canal is dressed with non-setting calcium hydroxide, which further aids in cleaning the resorbed area. Obturation. Gutta-percha, GP, and sealer are used for obturation, often employing a thermoplastic technique for satisfying condensation and adaptation in the resorbed area. In cases requiring internal reinforcement, dual curing composite resin and fiber posts may be advantageous over full canal filling with GP and sealer. Periodic follow-up appointments are essential to monitor the progress of treatment and ensure proper healing of the resorptive defect. Early intervention and meticulous treatment are crucial for successful management of internal resorption. Replacement resorption. Replacement resorption is a unique type of root resorption that occurs following severe luxation or avulsion injuries, causing damage to the periodontal ligament. In this scenario, more than 20% of the periodontal ligament is damaged or lost, typically due to factors such as dry storage of an avulsion or removal of the periodontal ligament before replantation. This results in the death of periodontal fibroblasts on much of the root surface. Clinical presentation. Ankylosis, the absence of a ligamentous joint between the tooth and its supporting bone results in the tooth feeling rock solid even when root resorption is advanced. Percussion tone, a bright metallic tone may be noted upon percussion. Radiographic findings, the root will appear ragged in outline, with no obvious periodontal ligament space separating it from the surrounding bone. Diagnosis and treatment. Early intervention. Pulp extirpation within 2 weeks of reimplantation should avoid the use of calcium hydroxide as the initial root canal dressing, as it may increase the risk of ankylosis. Dressing options. After extirpation, the canal should be left empty for the first 2 weeks or an antibiotic, steroid preparation can be used, followed by non-setting calcium hydroxide. Avoid letter mix due to severe tooth discoloration. Conventional root canal therapy. If endodontic treatment is not undertaken soon after reimplantation and the tooth subsequently loses vitality, conventional root canal therapy may be used to address painful periapical pathosis. Resorbable filling materials. Consideration should be given to using resorbable root filling materials such as root canal sealer alone or reinforced zinc oxide eugenol cement instead of gutta percha in cases of progressive resorption. Autotransplantation. In cases of progressive resorption, autotransplantation of premolars may be considered, with better chances of revascularization and further root growth if performed while the premolar's root is about 2/3 formed. Follow-up. Regular monitoring and radiographic assessment are essential to track the progression of resorption and determine appropriate treatment adjustments. Early intervention and careful management are crucial for addressing replacement resorption and preserving the affected tooth whenever possible. Pathological root resorption. Inflammatory resorption. External, includes external root resorption and cervical resorption. Internal, occurs within the root canal. Arrest, inflammatory resorption may stop if the underlying cause is eliminated. Replacement resorption. Not responsive to treatment. Root replacement by bone gradually occurs over time. Management. Preservation, maintain a resorbing tooth for as long as possible as it serves as the best space maintainer. Decoronation, in cases of moderate to severe infraocclusion, when the tooth is submerged below the plane, decoronation should be performed. This involves removing the crown of the tooth while preserving the root in the alveolar bone. This procedure helps to maintain the alveolar bone in the region and facilitates future placement of autotransplant or implant. Effective management of pathological root resorption involves understanding the type of resorption, addressing any underlying causes for inflammatory resorption, and considering appropriate interventions to preserve the tooth or the alveolar bone in the affected region. Pulp canal obliteration. Description: gradual hard tissue formation within the pulp cavity, leading to narrowing or complete obliteration of the pulp chamber and root canal. Appearance: reduced response to vitality testing, slight yellow/opaque appearance of the crown. Common occurrence: more prevalent in immature teeth and following luxation injuries compared to concussion and subluxation injuries. Radiographic appearance: may appear as complete calcification, but often a small strand of pulpal tissue remains. Management: considered a form of natural root filling. Treatment is not typically warranted unless signs of pulp breakdown are present. Injuries to the supporting bone. Assessment: verify extent and position of alveolar fracture, clinically and radiographically. Repositioning: if teeth are displaced such that their apices are over the labial or lingual/palatal alveolar plates, apical lock, extrusion may be necessary before repositioning. Splinting: rigid splintage for 3 to 4 weeks with composite wire, along with antibiotics, chlorhexidine, soft diet, and tetanus prophylaxis check. Timing: repositioning within an hour of injury improves pulpal survival. Root resorption is rare. Child physical abuse. Definition: treatment of a child in a manner unacceptable in a given culture and time. Prevalence: significant issue internationally, with numerous reported cases leading to severe injuries or fatalities. Signs and symptoms: injuries may include facial trauma, dental trauma, fractures, contusions, ecchymoses, abrasions, lacerations, burns, and bites. Considerations for suspected abuse. Evaluation of injury cause and consistency with clinical findings. Assessment of explanation, consistency and appropriateness for the child's age. Examination of the parent relationship and child's reactions. Inquiry about any delay in seeking medical/dental advice. Evaluation of injury, explanation, consistency. Observation of child's demeanor and parental comments. Assessment of previous injury history. Intervention. Identification of and intervention is crucial to prevent further harm. Dental professionals may be the first to suspect abuse and should be aware of local systems for managing such cases.